audience because I'm not really an expert at this one either, but nonetheless, here we go. I have no disclosures. I think we're all pretty much aware what porcelain aorta looks like. It's something we've all encountered in our practice. What I did learn about is, though, that there's an increased incidence as patients get older, and there's an association with coronary artery disease and aortic stenosis. It is associated with increased morbidity and mortality in patients that have cardiovascular disease. And as we know, it's one of the big contributors in post-operative stroke patients for our patients that have cardiac surgery. So there's a classification, and you can always find a classification for something. And there are two types. The type 1 is with a circumferential calcification of the ascending aorta, and that is then divided into two categories. Type 1A, we simply cannot apply a cross clamp to clamp the aorta, and type 2B, where clamping is possible, but at some risk to the patient. And then type 2 is circumferential calcification of the aortic arch or descending aorta. So two distinct differences. Now, the pathology of the calcification process isn't fully understood, and I'm not a pathologist at all, but there are two types that they are now aware of. Firstly is the intimal atherosclerotic calcification, and the second one is medial calcification. The intimal one usually results as a form of injury, and you get macrophage foam cell migration into that area. The smooth muscle then proliferates from the media to the intima. The lipid droplets are then slowly formed, and they gradually increase in size. And then the fibrous connective tissue forms, which then calcifies. The second type is the medial calcification type, and this is usually associated with some form of disease process, either renal failure, radiation, or vascular inflammation processes. And in these instances, there are phenotypic changes in the vascular smooth muscle, and they change to osteoblasts, and these then secrete proteins associated with the bone formation, and they calcify. Now, there are two diagrams, but unfortunately, they don't really project very well to just show the difference between these two groups of calcification. But I think in essence, just know that the medial type is usually associated with those disease processes I mentioned. So the diagnosis is obviously important for us to become aware of this before we end up in theatre with a patient, and obviously have high index of suspicion in patients that, for example, have renal failure on dialysis, or have some form of inflammatory disease like rheumatoid, etc. Often routine chest x-ray can be a good guide that it's present. And if that's the case, then CT is probably very advisable. You can look at the whole vascular tree and go all the way down to the femorals. MRI can be just as helpful. Also, intraoperative TOE can often help you get the diagnosis, but usually that happens in theatre and it's a bit late to find it. And of course, epi-aortic scanning, which Hero is an expert at, can also be helpful. Often angiography, which I didn't mention, can also help us see the calcification in the aorta. So the risk factors, if you have mentioned, we see it in patients that are of advanced age, hypertension, diabetes, dyslipidemia, a strong smoking history, renal failure, mediastinal radiation, systemic lupus, rheumatoid, and Takayasu's. Mediastinal radiation, that subset of patients is actually really a hard group of patients to treat. I think their valvular disease is difficult. They're often calcified into the annulus of the valves, and they're a very difficult subgroup of patients to manage. Nonetheless, CATS in 92 used TOE assessment of atheroma in the aorta, and as we can see, they're grades 1 to 5. I don't think that's all that important for us. It just shows that even in the 90s, we were aware of the fact that the aorta was the real cause of stroke in our patients that have coronary surgery. And this was designed to help us find these. There are other numerous publications I haven't mentioned. But this device, which I find is amazing that it has to be used in Japan, we use it a lot in our institutions as well. And it's simple, it's easily available, and you can use it at the time. And it can be very beneficial for patients to work out a different strategy if you didn't pick up on this preoperatively. I mentioned radiation, and about 10 years ago, I had a patient that had aortic stenosis. TAVI hadn't become freely available, or wasn't even available at that stage, and I heard of a catheter called the Pruitt catheter, and I thought, oh, well, this is my way to help this man. And there was enough space for us to do an aortotomy. We put him on femoral bypass. We put the Pruitt cannula up from the arch side, inflated it, gave cardioplegia, the heart arrested, and we thought, we're heroes, we're going to get this job done. We opened the aorta to find that this catheter was not designed to conform to calcification. It was an incredible mess with blood flying everywhere. Fortunately, we could get the aorta closed. And sadly, I had to take the patient with bypass without having an operation. So the Pruitt cannula, although it's designed to help occlude arteries, certainly is not suitable in a calcified aorta. You can take that from me. Now, there are a lot of publications I found that help us look at different ways to deal with clamping of the aorta. The first one was a group where they actually opened the aorta under low flow and low temperatures and apply the clamp under vision and then suck out all the debris and do the same when they reverse it. Not a technique I think I'd like to find. The second paper is from Japan, where they looked at porcelain aorta and surgical strategies for all types of valves, not just coronaries, which is more which I'm supposed to talk to you about. And of course, Gardini looked at a group of patients where they fibrillated the heart and regarded that as a non-touch technique and compared that to off-pump. And the fibrillation group did a lot poorer regarding stroke as well and renal failure. So it wasn't really the answer to dealing with these patients with porcelain aorta. This is a huge publication, a meta-analysis by a group from Australia. And you can see that David Taggart and Puskas was involved in the study as well. They found 13 studies, and there were 37,000 patients in the study, which were divided into groups of various forms of off-pump surgery, how they attached the proximal anastomosis if they were done. The important thing about the whole review was that there was evidence to show that if you did a non-touch technique of the aorta and off-pump surgery, that those patients were at lower risk of stroke. And the other benefits as well, that they had less renal failure, atrial fibrillation, and bleeding. So I think that really set the stage that these patients should be done as an off-pump. So obviously, when you get the patient referred, you need to work out how you're going to deal with this whole problem. And Michael Gardner gave a fantastic talk on radio coronary surgery early on about risk and looking for ways to deal with a patient that has a disease process that you're managing. And obviously, it all starts by planning very carefully, and obviously you should look at assessing the patient yourself, look at the angiography and the grafts that are required, be aware of the extent of the calcification, whether the femorals are involved, and if you need, can you put them on bypass if necessary. Then work out what conduits you're going to use, and from that, decide about your inflow. If you're not afraid with doing off-pump work and the femorals are okay, you can put them on fem-fem bypass and then do the grafts without occluding the aorta, but the best option without a doubt is the off-pump group. Now that goes with a certain skill set, and many people in ordinary care do this on a daily basis. To them, it's just the norm to do off-pump surgery. But I can tell you that in Australia, only a small group of people do off-pump surgery, and I don't. I can do it, but I don't do it a lot for various reasons. But now that I'm back in the public system, I can certainly restart that and get that going. But, you know, the skill set's important, involving anesthesia and how you set it all together to get excellent outcomes for the patients. But again, the group from Sydney done some beautiful diagrams where they use the right internal mammary artery as the inflow for the radial artery. And you can see on the right-hand side the different configurations of doing aortic surgery, which is probably the same as doing porcelain aorta. And I call this meeting the resurrection of the gastroepiploic. Michael Gardner, you saw, and I did quite a few of these. And then heard bad reports about a year or two ago about gastroepiploic and many stopping. But after what I heard at this meeting, I really think that we can go back to the gastroepiploic to use that for the inferior wall. It is a big conduit. I've done quite a few, and I remember that very well. But the key, obviously, is keratinization. And my co-chair is an expert at this, and he might have more to say about that a little later on. But I do think that this meeting, without a doubt, has resurrected the gastroepiploic artery, which I think is a great conduit. I just have a few angiograms from a colleague in Sydney who sent me these to help me out. On the my left side, your right side, you can see that the right inflow mammary was utilized as an inflow with a radial artery sequential graft to the PLV and the PDA. And on my right, your left, you can see a wire graft to the lemur to the circumflex system using the distal radio, I beg your pardon, the distal reamer for that. So these inflows can really change these patients and give you excellent results. And last but not least, this is a case we did. This patient's grafts are now 18 years old. He had his operation when he was 40. And he's still going really well, and you can see the benefit of wire grafting in patients using arterial grafts. So in conclusion, porcelain aorta is a rare condition, but important one, and you're better off knowing about it before you get to theatre. There are strategies available to make CABG safe with excellent outcomes. Arterial conduits are probably the optimum conduit to use, but venous wire grafts can be used with good results. And John Brereton, who gave me those angiograms from Sydney in the early days, used quite a lot of wire graft with vein, and at 12 years they look pretty good. And I wonder whether that's because they're not attached to the aorta as a first-order artery, but they're on a third-order artery with low impedance and therefore have better long-term outcome. But overall, aortic surgery or surgery in porcelain aorta can be done with good results. And if they require valve surgery, then obviously percutaneous intervention is the way to go. Thank you very much.
Any questions? Now, you know, this kind of meeting, we have a lot of experts of arterial conduit. But in fact, in the real world, we use arterial graft and also venous graft. Aorta is a viable option to use, and most of clinicians, I think. Have you used a vein graft for the bypass? Of course.
I have, but I haven't used one for about 9 months.
So, my question, we Japanese tend to do too many studies preoperatively. We do MRI, CT, or other X-ray study. What about in your system in Australia? Just routine CT scan of the chest?
No.
No, you don't.
No.
See, this is the difference. What about the epi-aortic scanning? You show it. That's a routine setup for the CABG suite?
Not unless you own a MiraQ, and we do, both in the public and the private hospital I work in. And I think it should be in Japan, like in Japan, mandatory in all patients, because you get a lot of valuable information from using it. So I use the epi-aortic scanning a lot. But if I know I'm doing a wire grafts in a young patient, I seldom would. But in general, I think rapport with cardiology is important, and in moderate lesions in the right coronary system, I don't graft. I just discuss with them and say stent them if they become an issue, and concentrate on the left system with arterial grafts. And that's why I seldom use vein. And I use bilateral mammaries in 80-year-olds with E. Didn't reconsider anything else.
Bypass is okay. However, if the patient having some reduced left ventricular function, it's more than moderate regurgitation. We have to think about it. So we have to go on pump in that situation. So we have to avoid that any complication. Do you have any comments from the audience?
There's one.
Or questions?
Sorry,
yes,
from Thailand. I heard you talk that you say that for the last 9 months you didn't use vein at all.
No.
What about the lesion that's, let's say, 50 to 60%?
I don't graft it.
70%?
70% I'll put a free reamer on if I have to.
Free reamer.
Yeah, but I won't use a radial, but I don't, 50 to 60% stenosis, I don't graft.
So you ask the cardiologist to do the stent for you, or just leave it?
If necessary, but in general, yeah, we'll do an FFR. We have a high or low threshold to do FFR on those lesions. And if they're FFR negative, then we just ignore them. If we have evidence of ischemia in that territory, then obviously that's a whole different ballgame, and then we'll consider using a vein. But in general, I'm very conservative on grafting non-high-grade stenoses, unless I have evidence of ischemia. I think this is the problem. I think we need a global approach. You know, we do angiograms and you see a high-grade stenosis, and we graft them because we know that's there. But there are a lot of work done in Europe by Volkmar Falk that showed, you know, multiple 90% stenosis in the right coronary system, and there's no way that they can show any ischemia in that territory. But we still graft it. But does it actually need a graft? I don't know. So I think it has to be a package. I think we have to look at viability if you're not sure. do stress tests and reperfusion studies if you're not sure. But I think in general, coronary surgery and graft failures happen because we graft non-high-grade stenoses. But having said that, I've seen 15 stenosis to open with a Lima to LAD, so it's a bit tricky.
One other question I want to ask Dr. Fair and Professor Asai about, in many 2 or 3 years back, I think I read some papers about when we do grafting or we try to do complete revascularization, sometimes we may graft too much. That may jeopardize your graft that you did it. Like you said, 7 or 9 or more than that. Sometimes in the long run, it's not as good as you do less graft. But I'm not remember what is the name of that paper. Do you have some opinions about this?
I'm sorry, I couldn't hear half of your comment. What is the specific question?
The specific question is that what is the limit of how much, sometimes too much graft is not good from some literatures that I read.
Too many targets,
too many graft may be not a good idea. Do you have opinions about
Yes. Maybe short. I may not answer to you directly to your question, but that's your presentation that, reduce LV function. Every single significant target should be grafted with a good bypass, period. That's very important. Otherwise, one territory, one good bypass maybe suffice. That's my opinion. I don't know. There's no... But in terms of that's aortic calcification is something. However, non-calcified aortic irregularity is also more dangerous.
Oh, absolutely.
Yeah.
And that's why I think epi-aortic scanning is so important to see those.
So that the
Those are the ones
scan
that
really
shower off.
makes a difference
Absolutely.
for us to take a look. Dr. Takemura?
Thank you very much. You showed one reason for the porcelain aorta is Takayasu disease. Takayasu disease.
Arteritis.
Arthritis?
Yep.
Usually for the young lady with the Takayasu arthritis, she has some stenosis on the subclavian artery or something, so it means that we cannot use the mammary artery. Do you understand me?
Yep.
Yeah, so in such situation, what would you do?
Use a radial.
Radio, should be. But she has a porcelain aorta. How to use the radio?
Use the inflow from the rema. Is that possible then? Oh, the gastroepiplaque.
Okay, thank you very much. It's very. Actually, I had a very, same situation with an 18-year-old girl with Takayasu arthritis, and right subclavian artery was stenotic. So just I put a Rima, inside Rima to LAD only, but we couldn't treat the circumflexor. But she recovered very well. So Takayasu disease have some another problem.
It's a whole different ball game. Yeah. We don't see a lot of it, fortunately.
Any more comment for audience?
No, I think I've worked with people that said you put a graft in each corner and the patient will be okay. I don't think that's the right strategy, just answering the question about doing too many grafts. But I think small vessels, grafts remarkably can stay open and patent, but in general, we favor going for large targets and target them when we do bypasses. But we've become quite conservative with moderate lesions. We don't tackle them unless we have evidence of ischemia or FFR, IFFR.
All right, thank you very, very much. Let's go to the next presentation.
computer is stuck, so I'll speak later. Stuck.
Computer? 뭐,先やろうか? Well, his computer is in trouble, so my presentation will be
Okay.
so fast.
So I'll introduce. You're talking about.
Asai.
Yeah, I know. Now my co-chair is going to give us a presentation. I think it's on the gastropy plug. I haven't got the topic up. Is that right?
Yeah, I talked about Cinderella artery yesterday, so I'm going to talk about
Cinderella again. Yeah, that's
next. Great. Can we see? It's done. Okay. So that's the second story of Cinderella. So today we focus on a more technical aspect of the harvesting and anastomosis. So GR was a very, very strange goal. GI is the largest branch of the stomach, and there are two different types of branches coming off from the gastroepiploic. And most of the time, large surface of the greater omentum covered almost 2/3. And as compared to IMA, ITA, other artery, including left anterior descending or muscular artery, only internal mammary artery having multiple elastic lamella. I don't know how that pronounced properly. But the GEA, no question, the one of the muscular artery, which is different from ITA. But it compared to radial artery, look at the thickness of the media and intima, significantly, thinner, or only radial artery is very, very thick, muscular. So sometimes SPY, intraoperative SPY fluorescent imaging, sometimes missed patent radial artery as not opacified. That is reported. Anyway, that thickness is pretty similar, but no question, gastroepiploic is the same way to the other artery. Only IMA is elastic artery. It is. And also, I mentioned yesterday, the distal part of the ITA, as well as the gastroepiploic also, the smaller part and the very distal part is more vasoreactive. So always harvest proximal part, that green part, adequately, and also try to discard this distal part, if not. So skeletonization makes a difference, I told you. So this I introduced because skeletonization, it's good. ITA, good for the GA. However, it's not necessarily easy. There are a lot of traps to cause injury of the branching of part, dissection, or maybe some bleeding from the vein. So actually, this harmonic scalpel originally designed for laparoscopic surgery. So it is convenient and nice. So this take out the anterior layer step by step and take care of gastric branch or epiploic artery all together or even separately, like this. So let's go to video. So that's sternotomy extended about several centimeters towards umbilicus. And the artery is always, oh my goodness, what's going on? I should have that. So I just catch only the arterial trunk. You see that that's this small tiny vein. Okay, I shouldn't touch this screen. Do you have a pointer? You don't. So every maybe several centimeter to pick up the gastroepiploic. In fact, until I started this skeletonization, I didn't know this gastroepiploic is such a large, huge arterial trunk. The reason it's conventional pedicle approach, maybe that's omental coverage restrained the arterial trunk to dilate maximally or just elongate maximally. There's no clear reasoning of the So the only thing, try not to injure the main trunk of the gastroepiploic artery. So it's about, I think, 10 to 15 minutes to take out about 20 centimeters of the, and after heparinization, divide it and put the intraluminal injection of a vasodilator. This is time diluted Mylenol to be used. Papaverine is okay also. So they're also wrapped with papaverine soaked sponge. You can put the grafting from any part, it's pulsatile, but this is not still maximally dilated. So this is another video which I start sternotomy. In another case, extended 5 centimeter caudally and cutting the diaphragm vertically, fibrous portion. I would close off to leave maybe 1.5, 2 centimeter slit. If too big, it may be some increased risk of post-operative herniation, which is very rare. However, we have to keep in mind. And the stomach is actually much larger than most of the thoracic surgeons think. This part with a good caliber also can be picked up. This is actually, you may notice, this old type of harmonic scaffold. New type having a different way to carve, so may need a little adjustment. But any surgical manipulation or some pharmacological stimulus change the caliber of vasoreactivity of these muscular arteries, especially gastroepiploic. So we always go to the level of pylorus. We can feel the thickening of pyloric ring by hand. So we go distally. As you observed, I always adjust a little bit intrapedicle space, because that would give us approximate idea of the where the target vessel is. At the same time, with this, we can limit laparotomy vertical incision. The same way, after heparinization, we put some medium-sized titanium clip and cut.
Then we keep that incubated until this is one to trying to get target site of PDA, posterior descending. I used modified Professor Yokoyama's technique to introduce the shunt. I didn't use a Dietrich this side. So anastomotic technique, if you have a sufficient distal lumen, let's say 3 to 4 millimeter in diameter, I just do the same way to the vein graft or ITA graft, which I use 7/0 or 8/0 Prolene running suture. In my previous experience, I think internal thoracic artery have more tendency to cause dissection if you do roughly. Gastroepiproic looks slightly more stable. However, individual difference exists. So we just keep that. So in contrast to the Dr. Suma, the Dr. John Pim's report, it said 1.25 or 1.5 millimeter internal diameter at the distal site of the anastomosis in a conventional pedicle graft. Our colleague Dr. Phuong from Vietnam showed that 3.9, 4.4, 3.6, these are median internal diameter at the site of anastomosis and skeletonized GA. So how big difference we can recognize. And the flow by transit time measurement was adequate also. So that's this kind of anastomosis is easily applicable. When I make sequential anastomosis, we can do parallel. At the same time, if we have adequate lumen, we do this kind of a crossing over diamond anastomosis as well, which we make maybe eight bites circumferentially, or maybe 10 bites. I always put some extra stitches outside the adventia, try not to cause any twisting or kinking, which is, I think, trap for the skeletonized graft in sometimes. It's hard to find that this is really twisting, not twisting or not kinking. But usually gastroepiproic have a little more larger lumen, also the ITA have more tendency to be twisted or kinked. We had a luxury of doing this kind of study. Well, anyway, what I want to do, I'm sorry, just, oh my goodness. I'm fine. The size of artery is huge. That I really wanted to show you the video. I'm sorry. Oh my goodness, no good. Well, this is a good GA. I'm pretty sure I bring that, one of the good one. I'd just caution you, there is some individual difference. Some are huge arteries, some are pretty big artery, some are ordinary. But I think it's with proper treatment, the size change dramatically. So try not to underestimate at the first look That's my message. So horizontal assessment sometimes was this kind of a snowman fusion. This is the idea. So it's a lot of different way of total artery vasculature only with the inside to graft can be performed with the tightly stenosed, especially younger patient, I think ideal. I think that's a list of things. We can go for circumflex area like this, and even 9 years later, it's very good. So this must be a viable armamentarium for a modern cardiothoracic, coronary surgeon. This is a magical touch. Thank you very much.
Thank you very much. That was a fantastic video presentation. And as I said, I think this is the resurrection of the gastroepiploic, and certainly we'll go back to using it in our practice. And thank you for showing us how you skeletonise. I think that was very valuable. Please.
Professor, there's two ways to make a tunnel of GA into the mediastinum. The other thing is use a hole, make a hole.
Mediastinum to fit your graft.
You put the GA
okay.
into the mediastinum in two ways, right? One is to make a small hole, and the other way that Professor do is just make it wider.
I just cut it open,
Cut it
but
open.
Close
Close
quite tightly. Don't lose too much big hole because that might be increased risk for postoperative hernia. That was, I think it's reported a few years.
I have some problems
Yes.
sometimes with the kinking of the anastomosis that compromise the flow after we test the TTF.
I see.
So is there any tips about how to make a curve of the graft, measurement the length, because it is quite high risk of kinking. What is the tips?
Very important question. I think there was some report. If you make a diaphragm just hole, not a vertical incision, I would recommend to make a hole on a distal right, parallel to AV groove. You understand? Distal right coronary artery running like this way, right? And on that area to make a hole to entrance. So that naturally goes to PDA or maybe rest of a target. That won't kink. But if it kinks, we can just cut open a diaphragmatic hole and make it naturally and the previous hole to be closed. That can be done also. But that's crucially important. You don't want to make any kink at the side of diaphragm. Did you get it?
Yeah, I
Okay. But I usually liberally cut vertically and close off sometimes. But vertical cut is not necessarily fit the routing of the GA. So I sometimes transversely cut a little bit and close the rest of things. You're right, that's natural cause is very important.
I personally have two complications of, I have the two patients coming back with ventral hernia after I do.
Did you?
I
Have
do
you?
2 cases.
Oh,
I think another tips that I don't know who's gonna teach. When you do extension to the upper laparotomy, the way when you close it and you have to put the chest drain from the lateral side of the incision, sometimes make it difficult to close the anterior sheath completely. I'm not sure that is the reason why there's a high risk of the ventral hernia after that or not. The way you put it in the chest drain, you have to penetrate through the anterior of the sheath first. Is it okay to do that or not?
I don't have the data, but there is almost 10 case report, and one is a review for that case report in the world, in history. I just writing textbook, so just found that. But initially, some Western paper, mostly posterior route into the pericardium was a high-risk case to be supported. But the recent case by Japanese was anterior course. So nobody knows. But no question, if gastroepiperic artery harvested and grafted too short, so that bring up the gastrointestinal components, also the higher intra-abdominal pressure, like a constipation, obesity, these kind carry high risk, according to literature. Okay, that's all I know about it.
Suppose your GA is so good, but accidentally we got some injury, so it's shorter than you expected, and you really need to go to the PDA. What would you do?
I just reconstruct a couple of cases to territories. I've accidentally cut and make it re-anastomosis.
The anastomosis with distal segment.
I'm not certain this is as good as no injured one, probably not. Okay, final thing is Professor Arai's facility just recently published post-operative follow-up abdominal surgery to be done safely. Some rerouting is needed for the gastroduodenectomy for the difficult operation. However, they have extensive experience, just published in annual thoracic surgery, I guess. Thank you very much.
Have you ever, before you go, have you ever had instances where laparoscopic surgeons in the abdomen, they see this big vessel and they go, I better just clip this?
So they need to be educated, at least before discharge. I think, patient and family should be strictly educated if any surgery of other part, because they don't have any clue what is going on. That happens in accident.
John Pym told me it happened to him in Quebec. Somebody's in the abdomen thought, what's this big thing? And they just clamped it and divided it. And
viable
infarct.
GA cause big life-threatening problem. Thank you very much.
Thank you very much.
Dr. Takemura.
Thank you very much. So this is the last presentation today. My talk is about the OPCAV in diffuse target, but I don't use OPCAV every time, so the title should be the efficacy of the epicardial echo imaging for the diffusely diseased coronary artery. In Japan, over half of the patients who undergo CABG are diabetic. It means that we frequently encounter diffusely diseased coronary arteries, meaning that the decision of the anastomosis site is difficult, and the anastomosis itself is very difficult. So I report here the efficacy of the intraoperative epicardial echo imaging to evaluate target coronary arteries and determine optimal anastomosis site in diffusely diseased coronary artery. I used this very ordinary echocardiograph machine from the GE, and it has 15 megahertz frequency transducer. And I used a sterilized hydrogel pad. It's a sonar pad. So just I want to present 3 cases. First one is 83 years old male with diabetes, with very diffusely, and the LAD was totally blocked, and the hilateral was severely stenotic, like this. Because I want to say that LAD is not visualized even from the right and the left coronary angiogram. Is the problem. So I use the mammary artery. So I always scan the coronary artery. You can see even for the scanning the artery, you can see some sclerosis and the narrowing. And anyway, we should search any site for the appropriate anastomosis site. So finally, I could find one spot, but after opening the artery, the intima was very sclerotic. So I should cut toward the distally. So eventually, I should do the arterectomy like this. So I decided to do the off-pump coronary artery bypass using the onlay patch plasty. So I cut the intima, cut off at the distal, and I fixed the intima. So I put maybe a 2.5 centimeter onlay patch using the internal mammary artery. Anyway, this patient has a totally blocked LAD, so we could do the off-pump with the bypass. So after that, we can scan the figure of the anastomosis like this. So postoperative angiogram showed very good result. The LAD and the diagonal, which was not seen in preoperatively by even in angiograms, but the result should be, looks very nice with a very good onlay patch. And you can see the septal branch and the diagonal branch also. This guy is a 50-year-old male with diabetes. And PCI was done for LAD 3 months prior to the operation. But just after 3 months later, after PCI, there was a stent fracture. And also, surprisingly, at the PCI period, the patient has no stenosis on the right coronary artery. But just after 3 months later, after the PCI, the ostial of the right coronary artery and the bifurcation of the posterior descending artery was very severely stenotic. Finally, we could find the patient was allergic to nitinol with PCI. So you can see the very interesting finding of the LAD. You can see some edematous tissue around the LAD, wholly of the LAD. Because the patient need a mitral plasty, I put on the pump, and you can see the very thickened LAD. And very narrowing LAD also. So I cut the LAD. You can see the LAD were very thick and very sticky. So I cut up to the proximally of LAD. So you can see the wall is very sticky, and it was very difficult to pass the needle through the artery. And also, interestingly, not only the LAD, but also the circumflex artery, all artery was thickened. It's kind of the finding of the allergy. So this is the postoperative angiogram. The result is good. Anyway, allergic for the nitinol was revealed after operation. So I had no option, meaning that I didn't take out a stent intraoperatively. So this is the final case. with a guy with 56-year-old with diabetes and hyper on hemodialysis. You can see that all arteries, all branches are blocked and also stenotic. And also the right coronary is blocked totally. And the right ventricular branch is also stenotic. So that's why I asked Dr. Nuttapon, how many grafts would you do? Dr. Pon, how many grafts would you do this patient? 3, 4? So anyway, and also the left ventricle was very poor, and with ejection fraction was only 18%. So in this case, I usually use pump, and the on-pump beating CIBG would be, I would do that. And aiming as many as possible grafting I would like to do. So this is the grafting, and just always scan the artery. So this is grafting on the right ventricular branch, and also, and this is the grafting for the posterior descending artery. We can see the target arteries very well if you use the epicardial echo. So this is the final grafting to the light PL, and this is maybe the diagonal and the high lateral and the obtuse marginal, and also finally the posterior. This is the maybe eighth grafting to the posterior lateral branches, like this. And also I put a liter to LAD also. This is the final. So you can see the 1, 2, 3, 4, 5 grafting for the circumflex area. And also you can, I'm sorry. And also you can see the grafting to the right ventricular branch and the PD and right posterior lateral arteries. And fortunately, data is okay also. And fortunately, the patient recovered very well. And the postoperative UCG showed EF recovered well, and with EF with about 40%. And the patient did discharge very well, like this. So during about 2 or 3 years, I did CABG over 200 cases, and I did the isolated CABG 155, and the OPCAV was about 100. It means that the OPCAV rate is about 65 or something, just average number in Japan. And the ITA was used to 217. And the mean number of the distal anastomosis was 4.2 per patient, and the mortality was 0. So just focusing on the diffuse anastomotic LAD region, there was 24 patients, and postoperative angio showed a very diffusely stenotic, but not totally occluded. There was 15 grafts, and there was 27 totally occluded LAD. And 9 LAD could be seen with collateral. It means it was very difficult cases for us. But intraoperative echo showed good patent LAD in the 14 among the 15 patients, and one is occluded. And also even for the patient with non-visualized LAD, if we use the echocardiogram, you can see the LAD inside patent on 8 patients, and 1 patient was occluded. So for these 2 patients, we did only patchy and arterectomy, and for the major patient with the LAD, which was seen in the epicardial echo could be conventional little ILD bypass. So, and finally, the hourly graft patency was okay. Oh, I cannot advance. I cannot conclude. Can you go ahead to escape? Oh, my computer is not good. It's okay. So I can read my conclusion. So the intraoperative epicardial echo provides us the very important information, the real image of the narrow or the diffusely diseased coronary artery, even when preoperative coronary angiography could not visualize it. So it's my conclusion, and thank you very much for your attention. Thank you very much.
Any questions or comments from our audience?
Yeah, I'd like to say,
Yeah.
job well done. Small diffuse vessels, good outcome, angiographically well done. Excellent work.
Yeah, that was beautiful angiogram post-operatively. It's, are there any case in your personal history that no graftable, I mean, you said even occluded area, you can find some little collateral.
Yeah,
What do you think?
unfortunately, so far,
You had,
I have no experience on which we couldn't bypass on the LAD. I always try to find any site of the anastomosis site of LAD.
I see. Natapam?
I have one question. Suppose LAD is very small and diffuse, barely seen from the dye, but the diagonal is run the wrong way, like a dual LAD. And that diagonal is big and very good target. Which target would you choose the IMA to go on, to go down? To the diffuse LED or to the big parallel diagonal?
If you can put on the data to LED, I prefer put a data to LED rather than the diagonal. And your diagonal is diagonal. It cannot supply the septal branch or something. So sometimes endoarterectomy I can do the endoarterectomy to provide some supply to the diagonal, also the septal branch also. So I've done more than 10 or something cases. The result is good, I think. So I need to try to put a data to LED.
I would say that's diagonal LED and septal branch. These anatomical spectrum. Some LED looks like really the extension of a septal branch and the intramyocardia. In that sense, that diagonals play important role. So depending on the case, I know what you're trying to say, but I think theoretically, Professor Takemura is right. Go ahead, please.
What's your experience about long Lima patches for these diffuse artery diseases?
Yeah, as I said, I did maybe over 10 cases. I did long only patch like Dr. Takanashi did technique. So it's okay because the LED was totally or very severely corroded. Even we do the open cap, nothing would happen. So yeah, we can do that. But even after, even if we use a pump, it's okay. Even on the arrest but beating heart might be suitable for such a situation because we can see the real vivid tissue. You can see the vivid tissue.
And do you prefer Everpoint needles for such diffusely plaqued vessels for anastomosis or a regular needle for doing the anastomosis?
Could you please
Do you prefer an Everpoint?
Huh?
Do you prefer an Everpoint needle, which is now being marketed as a preferable needle for a hard plaque to pierce the hard plaque than a regular coronary suture?
I'm so sorry. My ear is not working well.
But point, I mean, you're talking about some products.
Yeah, the Everpoint needle, which they are being marketing for
I know.
getting
There are
hard plaque. So do you prefer those needles for doing such anastomosis, or for you just, that's a regular needles?
プロリのね、エヴァーポイントって言って、なんかキレがいいという張りがあるけ
I
ど、そういうのを
understand you
好み
very
で使い
well.
ますか
Yeah, yeah, I like EVA point.
日本語で説明しよう。
I use the EVA point now. I'm sorry, I couldn't hear well, but yeah, actually for the very thickened and very calcified artery, the EVA point work very well. I'm not HCOM person, but I like it. Thank you very much.
Dr. Takemura, I have different views. I'm also a proponent of off-pump bypass, but I think it's very tiny, difficult vessel. Sometimes we are better off with completely bloodless field with cardioplegic arrest.
Yeah.
Don't you agree or not?
I agree. Yeah, it depends your
Depends.
experience and preference and but if we could do off pump, I think we should, yeah, for the very bad LV function.
I think any other question or comments, Professor Takemura? It's very difficult cases, but beautiful pictures. Thank you.
Thank you very much.
We appreciate that active participation for the whole discussion by, in spite of many people didn't come from the United States or some other country, but we really thank you for everybody to just having a good discussion. We're going to conclude this session. Thank you very much.